thank you very much for joining us today. This is obviously an event focusing on fertility and the issues it can cause in the workplace. It's aimed to try and improve your fertility knowledge, and also so that you can learn more about who is affected, the causes, the consequences, the treatment and the support that there is out there for you. About 3.5 million men and women in the UK, so that's about 1 in 6, are affected by fertility issues, and the physical, emotional and financial impact can be significant. Work, relationships and relationships in general can be very much affected, and feelings of isolation whilst people go through the fertility process are common. Infertility's got a wide range of causes, and there are many different treatments ranging from drug therapy to assisted conception to help with that. But it can have a devastating impact on people's lives while people go through it, and obviously the aftermath if it's not successful. And 90% of people who go through a fertility process can have feelings of depression. So there's lots to learn about this very sensitive topic, and I'm very pleased that I'm joined today with 3 experts in this field, and I'm going to give you a little bit of information about each one today. Thank you all 3 for joining me. First of all, we have Alice Matthews from Fertility Network UK. Alice has worked in the charity sector for over 14 years, providing advocacy, support and engagement for those affected by discrimination and health issues. She's been with the Fertility Network UK since 2016 and developing the service basically across Wales and coordinating a team to provide one-to-one support for those affected by this. Her aim is to reduce feeling of isolation and the social stigma linked to infertility, improving, sorry, there's people in the waiting room, just going to let them in. There we go. Improving people's knowledge and understanding of reproductive health and fertility treatment. So welcome, Alice. Just before I go on to introduce my next 2 guest speakers, I just wanted to let those of you who have just joined to know that we are recording this session, and if you've got any objection to that, to let me know ASAP, please, because we are going to be sharing it with others once this session is over. Next, may I introduce you to Dr. Ariana D'angelo. Ariana has more than 20 years experience and publications in assisted reproduction and ultrasound, and she's recently released her first textbook in this field. After obtaining her first qualification in reproductive medicine at the University Hospital of Palermo in Italy, she trained in obstetrics and gynecology at the University Hospital of Wales, Cardiff, where she currently works as consultant at the Wales Fertility Institute. She is a senior lecturer in obstetrics and gynecology at Cardiff University and is also the ESHRE UK Clinician National Representative and member of the ESHRE Ethics Committee. So thank you very much, Ariana, for joining us today, and we look forward very much to hearing from you a bit later. And finally, the other speaker is Helen Corsi-Cadmore. I hope I've pronounced that correctly, Helen. Helen is a multi-award winning business consultant, coach and fertility coach who is passionate about helping others succeed. She's an entrepreneur from a young age and has been recognised as the top young business professional in Wales. She's also a strategic volunteer for the Ectopic Pregnancy Trust, which is a charity very close to her heart. And I look forward to hearing as well from Helen a bit later. Just in terms of housekeeping, I've already explained about the recording, but we will also take questions or comments through the chat function, if that's okay, so as not to disturb the speakers as they go through. So if everyone could observe that, please, and we'll come on to do a Q&A at the end. And just by way of short introduction, last but not least, my name is Fleer Jones, and I am partner and head of employment here at Darwin Gray Solicitors. And I am going to discuss with you some of the aspects of how fertility issues can affect the employment relationship, looking at how employers and employees are affected in that regard. And I will be speaking last today. So with no further ado, we will start by allowing Alice to come on board and present to us her sort of thoughts on the issues around fertility in the workplace. Thank you, Alice.
Oh, thank you very much. Can you hear me okay?
Yes.
Lovely. And can you see my slides?
Yes, we can.
Fabulous. Oh, well, thank you very much for having me here. I'm just going to check the time so I don't go over. And if I am going on, just please tell me to stop talking. So it's lovely to be here today. My name's Alice, and I work for the national charity Fertility Network UK. So we are a support organisation, so we provide impartial and information and both practical and emotional support to anybody who is affected in any way by a fertility issue. As Fleur said, we work to educate young adults about reproductive health and what things might impact their ability to conceive in the future. We support people who are trying to conceive and they're going through investigations or treatment. And then we provide support to those who've had successful treatment. So they're in pregnancy and those pregnancies come with heightened anxiety. So we support those people. And then unfortunately, fertility treatment doesn't always work for people or it wasn't the right path for them. And we provide a network of support to people who are childless, not by choice, but by circumstance. So it's kind of varied what we do. We also do fertility in the workplace sessions, talking to employers about how we can make our workplaces more supportive. And we lobby for more equitable treatment across the UK because there is still a postcode lottery. Okay, so today I'm just going to quickly run through, kind of give an overview of the issue. I apologise in advance if people on this call know all this. It's a real whiz through. I can't go into too much detail, but amazingly, we've got three experts here. Ariana is going to talk about all kind of the treatment side of things. Helen's going to talk about the workplace side of things. So I'm just basically giving a bit of an intro and telling you here we are here for support for you. And if you know anybody who's going through this, be it a family member, colleague, a friend, please talk to them. Let them know that you understand how difficult this is, and please point them in the direction of support organisations, because talking and getting peer support can really help with those feelings of isolation. Okay, so infertility. So it's classed by the World Health Organization as a disease of the reproductive system. And it's basically a failure to, any form, kind of a failure to conceive. And there are many different types and causes, different causes of it. So basically, you have primary infertility, where somebody has never conceived a child and is having problems. Secondary, where someone has conceived a child before, but now they are having problems conceiving or going to full term in a pregnancy. And subfertility, which basically describes any form of reduced fertility for a prolonged period of unwanted non-conception. So they're the types. Now, the causes are many, but I just want to quickly recap the kind of the scale of the issue. So Fleur said 1 in 6 couples will have a problem, but it is more than this. 3.5 million roughly across the UK, which equates to roughly 1 in 6 heterosexual couples, but that is heterosexual couples. The number will be higher. People some people won't present with a fertility issue and will never seek help. Some people will decide treatment is not the way for them, so they are affected and they go through a grieving process, but they're not really captured in the numbers. And a lot of people go through it on their own, and obviously same-sex couples as well. So I think the number is higher. Now, generally, it's kind of viewed, I think, still a little bit in society like a female issue, but it's not. Roughly of those identified causes, about a third are a female factor, but a third are male factor. And in a third of cases, it could be both male and female, or they just don't know. So about up to half of all cases are male factor, so it's really important to acknowledge that. Okay, and the causes, there are endocrine disorders, so that would be problems like polycystic ovary syndrome, other hormonal issues, problems with the thyroid and the pituitary gland, things like that. Then disorders of the reproductive system, so things like endometriosis, which in itself in the workplace, if you suffer with endometriosis and it's a chronic pain condition, I think we need to be aware of things like that as well, which we don't have time to talk about now, and I don't want to go on a big rant about that, but those conditions can really impact in the workplace as well. Other things like scarring, polyps, things like that. And obviously then we've got problem physical disorders. So it could be something kind of fairly obvious, like somebody with a severe eating disorder, or it could be things like physical disorders to do with the sperm, so problems with the shape, the morphology, the way they swim, the number of them. And finally, it could be unexplained. So in about 25% of cases, a cause is not found. And you can imagine the impact on people never actually getting a diagnosis. They're trying to have a baby, which everybody else seems to be able to do. It is not happening, like one of the main systems in our body is just not working, and they do not get a diagnosis. So that, you can imagine how difficult that would be if you think about another system in the body, how you'd feel without a diagnosis. Okay, so I'm going to give a real whiz through of a typical kind of journey. So if you are listening today and you haven't experienced this, or you don't know too much about it, then this is kind of an overview. So first of all, we start in trying to conceive. When you decide, you have those conversations, you want a baby. I mean, it's so exciting, so thrilling. You're making all these plans, when you want it to be born, crazy really. Our minds go ahead of us. Have this fabulous time trying to conceive, which is just really great fun. And then the worry starts to creep in. Your friends are starting to say, oh my gosh, I'm pregnant, when's it going to be? Oh, I wanted it to be us to be together doing it, all those things. Oh, and then this like niggle then starts to creep in, and you're worried. Time goes on, you keep trying every single month, you keep going at it. Pregnancy test after pregnancy test, negative. The disappointment every single month when your period comes. Now, for somebody who has not experienced that, I think it's very easy just to not think about it, of course. But can you imagine waiting for your period every month, hoping it doesn't come, hoping it's worked, and then it comes, and the disappointment, and then having that conversation with your partner, oh my gosh, or if you're on your own with a friend, and then having just going to work and then somebody in work announces, I'm pregnant. Like, that's amazing, but you can imagine what's going on in their head. Okay, so you go to the GP first for your initial investigations, and they'll be talking to you about general lifestyle. They look at your age, because age is pretty much the biggest factor, especially female age. Smoking, they will talk about things like smoking and body weight. They should be giving good advice about smoking cessation. They should be talking about age and the way fertility declines with age, and this should be starting earlier on than it does, in my opinion. And body mass index, they should be giving really good advice about how to improve nutrition and be more active, and not just say you have to lose weight, but actually provide resources, which it doesn't always happen. And they'll talk about medical conditions that you might know, pre-existing medical conditions. They should organise for bloods to be done to see kind of if there's ovulation is kind of looking okay, and also semen analysis. Some GPs will do that. So at this stage, you may get a diagnosis. They might be able to say, listen, you're smoking a lot. If you can give that up, your sperm is likely to improve. Or they might say, listen, you really are a bit underweight. That's maybe why you're not having your periods. Increase your nutrition, really think about it, but it might happen then for you. But more often than not, there needs to be more needs to be done. So we carried out a survey back in 2016 now, so a little bit old, with Middlesex University in London. Of those we spoke to, 74% said they didn't get sufficient information from their GP. There was generally a lack of awareness about fertility and the pathway and what needed to happen and when. Okay, when you get referred then into secondary care, the first thing in this journey is the waiting. So you're waiting for your secondary care appointment, and that can seem, well, like an eternity, because you keep trying, hoping that you'll be one of those people, oh my gosh, she tried, she had all this treatment and then she got pregnant. You're hoping you're one of those. Everybody keeps saying, love, if you'll relax, it will happen. Just go on holiday and have a couple of drinks, all those sorts of things. Okay, everyone's really well-meaning. But you're waiting and you're anxious about your appointment, waiting for that appointment letter. Then you'll go into your secondary care service within one of your hospitals, and you have basic treatments and in further investigation. So again, they're looking at ovulation, they're looking at your tubes, tubal patency, to make sure there isn't any scarring or furring within those. Now, something I have to mention is STIs. So many people have an undiagnosed STI, and this is the leading cause of pelvic inflammatory disease, which is essentially this furring up of the fallopian tubes. So if you don't take anything away from this, just encourage any younger people to make sure they use protection and get regular testing, because if it's caught early, this is prevented. Sorry. Okay, so you may get a diagnosis or not. Then you're waiting. Again, you're waiting for your surgical procedure. Maybe you need to have your tubes cleared, or you might need to have polyps or something removed from the uterus. Now, I've put barriers to treatment here because the next stage, if none of this works, if you can't identify a problem, or you have something done and you're told, right, go on, crack on, see if it works now, and you get pregnant, fine, that's your course of action. But for those then who will need further investigation and treatment in a tertiary centre, there are barriers at play here. The first one, really important for anyone who's kind of in this stage of the journey, is your BMI. If your BMI is over 30, they will not accept a referral for you. So the sooner you know that, the sooner you can get some support. We run a fertility weight loss support group, which is really fabulous. We have loads of, it's motivation for each other and understanding what it's like to be told, oh, you're too fat to have a baby. So that is the support we offer for anyone if you want to signpost. Now, barriers to treatment, again, will be smoking. If either of the partners smokes, you will not be accepted for treatment. So even if it's only a female factor issue, and it's only her who's having the treatment, the male will still be tested to check he's got no nicotine and even nicotine containing products. So that's really, really important, that could be a barrier for you. And the most frustrating is obviously age. Under the age of 40, if you meet the criteria, in Wales, women under 40 are entitled to 2 full cycles of assisted fertility treatment. If you are over 40, up until your 43rd birthday, it's 1. So age is a real barrier. Okay. Then tertiary care. So you're waiting for your appointment, and obviously I have to mention COVID times have gone up. The clinics have been under huge pressure, and they've worked well. I don't know how they've managed. It's been incredible, but there is extended waiting, which again, talking about age, is a massive issue. Then you have your planning with you'll meet your lovely doctor and or your nurse, and you'll start talking about what's going to happen. So this is exciting. This is trying to conceive. This is exciting again. You have a cycle of maybe IVF or Icc, which Ariana is going to talk all about. And then in many cases, it doesn't work. You have a feeling of bereavement. You have that negative test, the pregnancy that it could have been, and you have a bereavement. Further barriers to treatment, again, if people are feeling really awful and they have to wait again, maybe their BMI creeps up, which means it's hard for them to get that second cycle, or the age is an issue. Further planning, another cycle, potentially another failed cycle. Barriers to treatment, you're looking at financial. If you had your 2 cycles of NHS treatment, you are then looking at funding this yourself. Further planning, going back down the route of treatment. Now, for some people, they have their first cycle and they are successful. But for some people, and a large portion of people, this cycle can literally go on for years. So I've written it like this. It's like a ludicrous list, but I just want to show that it's literally can go on for years for people. And we'll talk about finances in a second. I don't have a huge amount more time. Okay, obviously there's physical impacts, which Ariana will talk about. Financial, huge, roughly potentially about £5,000 or more for a treatment cycle. And like I say, it can take many cycles for people. People remortgage their homes, they have to borrow money off friends and family, things like that. So really stressful. They put their life on hold, basically. No holidays, no nothing. Socially, well, everybody's got a family. It's all about family. Everything you watch on television, Easter, Christmas, Mother's Day, Father's Day, it's all family focused, which, you know, is brilliant. But when you don't have that family, how do you fit in socially? Emotionally, the impacts, I mean, it's really hard. If you want a baby, you want a baby, and it's not fair. And obviously we have implications in the workplace. It massively affects people's work. From that, the survey, 70% reported it affected their relationship negatively, and you know, not just a partner relationship, you know, your intimate relationship, but others as well. Sisters' relationships breaking down, strains with their parents, you know, feeling huge amounts of guilt for not being able to give your mum and dad their grandchild. Friendships, feeling jealous of your friends and not being able to go to that barbecue again and talk about everyone's children. It's really, so as an employer or within the workplace, you need to be able to see that actually they've come away from that weekend feeling just wretched because they haven't got a baby. They walked through Tesco's and seen baby clothes on the way to work, and yeah, it's like being stabbed in the stomach. Okay. The emotional impact, just more things that people say to us all the time, you know, taking over people's lives, feeling so alone, isolated, the feelings of isolation and panic, like, oh my gosh, if this doesn't work, I will never be a mum, really difficult. And from this report, 90%, as Fleur said, felt feelings of depression. Actually, 42% had suicidal thoughts, which is quite alarming, really, but not surprising because the drive to want a baby for many individuals is so intense, and you can't have it. It's really awful for people. Okay, so when we're talking about fertility in the workplace, obviously people are going to be affected in work. When we've looked at all those quotes, how couldn't they be? We believe at Fertility Network UK that an understanding workplace can really positively impact the experience, basically, for people contending with this and going through it. If you know you've got a bit of support in work and that you're not going to have a difficult conversation with your line manager if you need some time off or some flexibility, obviously it's going to make you feel happier. So it's really important. From this survey, you can see that men and women did have conflicting demands of work and treatment. And obviously people's experiences massively varied depending on what they had in work, what they had in their policies, and how supportive their colleagues and line managers were. 58% reported work affected their treatment. 85% reported treatment affected their ability to concentrate in work. And obviously people were worried that they were going to be their career was going to be impacted, and for some it was. So to make a supportive workplace, I mean, Fleur's going to talk about this, but it's about understanding, just having an understanding, talking, making it acceptable to talk about it, and potentially offering through your OC Health and things, some counselling and support. And also considering people who, like I mentioned earlier, child is not by choice, and it can't all be about family and children for them. We can help you, Fertility Network UK, we can work with you to just increase that understanding. We can help with policy suggestions, with loads of employment fact sheets and things like that we can provide you with. And obviously we can support anyone within your organisation who's going this through. We've got so many different groups. And all you can do is learn about it and just listen to people and make it a bit easier for people. We've got loads of support and offer, which I'll share after this, but we have groups, we have online groups now, so many webinars, we have a network of peer support, our online forums, we have our former fertility nurse Diane who can help with medical things, our website with fact sheets and things like that, and yeah, that's me, and I did go over, but I hope by not too much. Thank you. Stop my share. There we go.
Thank you very much, Alice, for that illuminating talk on the process and some of the issues that people experience whilst they go through it. Is a very good overview to get us started on this topic, so thank you for that. I now pass the reins over to Dr. Ariana D'angelo. Thank you, Ariana, and there's her slides up. So I will, with no further ado, hand over to Ariana. Thank you.
Thank you. Can you all hear me okay? Yeah? And see the slides, yeah?
Yes.
Lovely. Thanks a lot. Thanks for the kind introduction, Fleur, and also for Fertility Network and Helen, and they're being great to actually invite me to give this webinar. I will talk about fertility investigations and treatment and give a little bit more insight on the fertility journey, as my colleague already did. So let's progress here. First of all, I have no conflict of interest for this event. So the objective of my talk today are basically to give an overview on fertility investigations and the time needed for these investigations for both men and women, as we learned that fertility issues do affect actually both sex. I will give an overview on assisted reproduction treatment in terms of procedure, again, the time scale involved in each procedure, the emotional impact and the practical needs for patients. And then things that can be done, perhaps some little tips that can be done to make the process a little bit easier, less stressful, as Alice has already mentioned, and ultimately more successful. Some strategies to create a supportive working environment. And I will touch just a little bit on fertility champions to support patients in the workplace, because this will be probably the talk of our next speaker. So to start again is a little bit of a repetition from Alice's slide, but basically just to say that the difference between what we call primary and secondaries of fertility. Primary is if you never had a child before, and secondary is basically the condition that affects people who have had a child before or who had been pregnant before, not successfully. The figures, again, similar to what we've been discussing this morning, is roughly 1 in 6 couples, but as Alice mentioned, really, it's not just couples, it's also single individuals, it's same-sex couples, and also people who do not disclose having fertility issues. Overall, the reasons are, most common are actually listed here, but just to make everyone aware that usually 30% of the reasons, including tubal and ovulation, endometriosis, it actually involves the woman, and around 30% involves the man, and then there is roughly around 30% which is unexplained. And also we have a small percentage of patients who have both male and female reasons for infertility. So you could have a male factor in a woman with endometriosis or tubal problems. So it's not always black and white, but there are several degrees of gray, really. So we start with investigation. I'm just gonna show you roughly what it is suggested doing, for fertility. And the first things, you want to make sure that you got your main ingredients for the recipe. The main ingredients are eggs, sperm, and tubes. That is what you need to have a baby. So I always tell my patients, we just check the ingredients first before we bake. And it's just the way to try and to reduce the pressure they are under, because the first time you see a couple or even an individual, single patients, they are always very anxious. And they are anxious because they don't know the reasons, and they are worried to find out terrible news, or even to find out no news at all. So what we do check hormones, and these are hormones that have to be done at a specific time of the cycle. So they will require the patient actually to go on several occasions for blood tests, and that might be the beginning of the period. So between the 1 and the 3 of the period, they need to check the FSH and LH, which are the hormone of the menopause. So it's very important that they are all nice and low. The progesterone, which is the hormone produced after you produce the egg, so showing that you have ovulated, should be done between day 21, 22. So these are days that are actually fixed, and patients might need to take time off work on these days because they have to have these investigations and they are not in control of their own cycles. The AMH is the anti-Müllerian hormones, which give us an idea of the egg reserve of each individual woman. And that can be done anytime during the cycle, as well as the prolactin, the thyroid function that usually are done when there is an issue with irregular periods or irregular cycles. So normally this test and the AMH are associated to one of these two visits. General health check recommended: full blood count, fertility, level of vitamin B, vitamin D. We are learning more and more now that the vitamin D is actually, a lack of vitamin D is associated with difficulties in conceiving, and because we don't see the sun that often, that could be one of the reason for having difficulties. But also the vitamin B is very important because it drives, all the neurological mind, the brain, the neural system. So it's very important. Chlamydia test. We always request a test just to make sure that there is no sexual transmitted disease. And then ultrasound and tubal assessment. Now the ultrasound, as you can see here, it takes around maybe half an hour, 20 minutes to perform. And I will show you practically how is it done. But again, that is another half an hour of your time, of the patient's time, to go through these investigations. If we, during the ultrasound, inject some contrast medium, we can highlight the fallopian tubes. You can see here the uterus inside. This is the white is actually the contrast medium, and this is the left fallopian tube that can be highlighted only if you inject a dye. Otherwise, normally we won't be able to see the fallopian tubes unless they are damaged. And this test is called HICOSI, and it does take around half day of your time. to be performed. The same way is the HSG, so the test to check the fallopian tubes by taking X-ray picture. So very similar to the Icc. So these are two alternatives to check the tubes, either, you know, via ultrasound or via X-ray, but still it will take around half day of your time to have this test. Plus the rest of the day you might be a little bit sore and you might want to take the whole day off. This is the image of the uterus, very nice, normal uterus, nice triangular uterus, and these are the tubes, right and left tubes, and you can see the tubes are really fine and very, very tiny, but when you see a lot of white at the end of each tube, that means that they are open. So we inject the dye from here, and the dye goes all the way through the tubes, identifying them, and then it will just impact or spill on the bowel, and this is bowel which get white because of the contrast medium spillage. So this is a good test, saying that the tubes are open. It also works very well to flush the tubes. So both these two tests are very useful sometimes also for as a treatment, because we flush the tubes, and some patients seems to conceive within the 3-4 months from the tubal flushing. But so this is just to say that investigations requires time. It's not just one-off visit and that's done. It's more than one. This is an image of our inside, which some people find a little bit gross, but actually this is how a womb looks like from the inside, through the belly bottom. So you put a telescope through your belly bottom, and then pass a telescope called laparoscopy and have a look at the uterus, have a look at the tubes, have a look at the ovaries. The white, those two white almond-shaped structures are the ovaries, and you can see they are not all white as they should be. There are some black spots, and this is a condition called endometriosis, which Alice briefly mentioned, which could be really devastating for women because it does affect most of their fertile time, their fertile life, and most of their cycles, in particular before having the period and during the period. What happens is that these little dots here will bleed inside. So this is part of the lining of the womb, which is dislocated outside the womb, on the ovaries, on the tubes, on the bowel, on the back here, the rectum, sometimes in the bladder. And anytime the woman has the normal period, will bleed inside, and that causes excruciating pain. And sometimes women have to take time off because of work, because they can't literally even walk. So this is one of the reasons of subfertility, because when the endometriosis affects the fallopian tubes, that is when the scarring will block the tubes by making impossible then to conceive. So you can see here now the discrimination. So I spoke 2-3 slides, 5 minutes about women. For man, it's only one visit. Within an hour, they produce a sperm at home, and they can just drop it in clinic. Most of the times it's a straightforward investigation. These are the little sperms that we look at them under the microscope. We look at the volume of the ejaculate. We look at the number of sperms, and these are the new values from WHO. 15 million is the average normal sperm count, and 32% of this count should be the one that are moving fast forward. So we want the sperm to be motile, but also we want it to be moving in the right direction towards the egg, because think that the sperm, once it's ejaculated in the vagina, has to go all the way through the neck of the womb, through the uterus, through the tubes, and then reach basically the egg. So we want the sperm to be fast. And then we look at the morphology, which is the shape of the sperm. You can see here lovely sperms. They got usually head, a middle piece, so a little neck and a tail. And we see that in 4% of the sample, but actually 96% of the samples is abnormal and as considered fine. So at the end of the day, you only need one normal, nice looking sperm to inseminate the egg. So moving on then with the diagnosis, as Alice mentioned, once the diagnosis is made, then we offer treatments, and most of the times are assisted reproduction treatment, ranging from intrauterine insemination, when we actually inject the sperm inside the womb and make it happen a little bit natural, moving to IVF, which is the in vitro fertilization, when you put the eggs and the sperm in the dish and wait for the sperm to get inside the egg and create the embryo. This one here, which is the baby. Or ICSI. ICSI is intracytoplasmic sperm injection. So it's this picture here, which basically, this is a needle. It's done under the microscope. The needle contains the sperm inside, and this is the egg. The egg is held by this holding pipette, and the needle goes inside the egg to inject the sperm inside the egg. So it's a way to make the fertilization happens when, for example, there are not enough sperm, so the sperm is still, it doesn't move, or if there haven't been any fertilization with IVF. So there are different indications for ICSI. And ICSI is the high-tech fertility treatment, very similar to IVF in terms of process, but obviously completely different under the laboratory point of view. The final results is always the embryo. So the embryo that you can see here is very much the egg. You can see the resemblance here with the egg. So most of the embryo is made by the egg. The sperm contributes to the genetic material. But that's why it's very important that the age of the woman and the egg quality, because as you can see, the content of the egg is exactly the content of the embryo as well. So very important that we look after our eggs from a young age. And that is a message that we are trying as fertility societies to push through also in school now about, fertility education. So here you can see the embryo, each individual cell can actually give a baby. So if you take out one of these, then that will give a baby. And that is when sometimes this happens naturally, not naturally, but also in IVF. And that is when you get twins or triplets identical from one embryo. What happens is this embryo will develop, each of these cells will carry on dividing and dividing. This is around 1, 2, 3, 4, 5, 6, 7, 8 cell embryos, but when they carry on dividing, it will become then a blastocyst, which is a bigger embryo, and that is the right time to transfer the embryo back. Overall, this treatment lasts around 4 to 6 weeks. Just the actual treatment. So it's not like, I give you a tablet and I'll see you in 3 months. It's more than that. And I think that message has to go through the employer as well and through the workplace. So once we start the actual fertility journey, there is a first appointment to sign the paperwork. This is more than a mortgage application. It takes at least an hour of both partners' time to bring all this documentation, to sign all the forms from the Human Fertility and Embryology Authority, which is our authority, the UK fertility regulator. There are lots of forms to assess the welfare of the child, forms to consent disclosure of information, forms to consent for treatment, any treatment, IVF, ICSI, frozen, the in-house consent to consent for the actual retrieval of the eggs, transfer of the embryos, and also the HFA consent. And this is just a standard IVF procedure. Obviously, if there is an involvement of a donor sperm or donor eggs or surrogacy, the forms are even more than this. So this process is quite lengthy and quite time-consuming in a way, but it is very important that the right information are given to the couple, to the patient, and the patients make an informed, decision to go ahead with the treatment. So just to summarize what an IVF cycle involves the stimulation of the follicles, the follicular growth in the ovary. So this is an ovary. The ovary contains follicles, and each follicles contain an egg. So what we do is we give injections, and I will describe this process in more details, to make these follicles to grow, so that we can then collect the eggs, aspiration of ovocytes, which is a step 2. These eggs are collected and they are placed in a tube together with a sperm here, and that is the IVF, or the Icc treatment. As I mentioned, we inject the sperm inside the egg. Then we check after 24 hours to see that the egg is fertilized, and we keep these embryos in culture for 5 days. And then on day 5, or on day 3, depending on when the embryos are ready to go inside the womb, we will transfer the embryo back. So that is the step 6. And that is done through a fine catheter through the neck of the womb. So this is the vagina, and this is the neck of the womb. The embryo then is gently placed inside the uterine cavity. So I will now describe each of these briefly. The stimulating of the ovaries to produce eggs involves daily subcutaneous injections of hormones, and these hormones have to be administered every day, sometimes twice a day. And the aim is to recruit between 5 and 15 follicles. So this is the image of the ovary. You can see all these black areas are the follicles, and these follicles are starting to grow. And we use ultrasound scans to monitor the response to the stimulation. And when the follicles are around 17-20 millimeters, that is when the eggs are ready to be collected. During this period, the woman experiences lots of difficult mood swings, hot flashes, symptoms, related to the actual hormones that she has to inject. So if there is downregulation, which means basically a medical induced Hi, can you hear me? Yeah. So sorry, I was saying they experience these side effects, headache and tiredness. The hormonal stimulation, which is the time when actually the ovaries the follicle starts to grow inside the ovaries, the woman will be feeling very bloated and heavy, and occasionally she will experience some nausea and sometimes some pain, depending on how heavy is the stimulation. And then when we transfer the embryo, we will give some progesterone to help the embryo to implant. And that can give some side effects like constipation, discharge, again, feeling bloated and experiencing headaches. So these are all considered normal side effects of the treatment, which occurs in many patients. And we tell the patients obviously they're going to experience that, and that can affect obviously their concentration in work, can affect the work, the life anyway. So the ultrasound scan is usually performed during a treatment cycle between 3 and 4 times, perhaps almost every other day at some point towards the end of the actual procedure. It is an intimate and investigations. This is the probe here, which is like a finger, really like a tampon, and the probe is inserted inside the vagina, and then we move the probe in such a way that we can identify the ovaries, as you can see here, or the uterus. And what we do is we measure these follicles. So you can see here these black areas. These are the follicles that contain the eggs, and this is a stimulated ovary. So at a regular interval during the treatment cycle, we will ask the woman to attend for an ultrasound scan so that we can take the measurements of the follicles. And then we plot the average measure of each follicle in a grid, and we can see how the follicles are growing during the stimulation. And when they reach a certain stage, around 17-19 millimeters, that means that the eggs are ready to be collected. So inside each of these, there is an egg. So preparing for egg collection then, so that is the very important time. Everything that we do is very well timed because our body is like a clock. You know, we work, the hormones have a certain rhythm, and it's very important that patients do the injections and follow the instructions properly, because there is always a reason behind that. It's not because we are, you know, a bit sadistic, we want you to inject midnight. It's because it takes 36 hours for the injection to work, to make the eggs to get mature. So it's very important that if you have your procedure around 11:30 in the morning, you take the injections 36 hours before. If you take it too early or too late, the risk is that you might ovulate, so you might release the eggs not in time to be collected, or the eggs will be immature, so they didn't have enough time to be exposed to the 36 hours, and that will mean that the process is failing, because immature eggs cannot be fertilized, they can't become babies. So the eggs are usually collected under conscious sedation. The procedure is a small surgical procedure. It will involve passing the needle through the vaginal fornix inside the ovary, and then the aspiration of the eggs. It takes around 15-20 minutes to do both ovaries, depending on how many follicles, how many potential eggs are there to be aspirated. The sedation will make the procedure painless, so normally there is no general anesthetic. The patient usually is awake but pain-free, and she's in control of the drugs that we can administer. It usually requires to be nil by mouth for 6 hours before, and also you won't be able to go back in work or take legal decision or work decision or drive for 24 hours because of the effect of the conscious sedation, which is basically morphine. So that's very important that you take some time off. The embryo transfer is the time when we transfer the embryo. This is a beautiful image of a blastocyst. So this is like a miniature baby already, and we load this delicate cell, you know, bunch of cells inside the syringe here, inside the catheter, and we gently transfer the embryo inside the womb. The procedure itself takes around 10-15 minutes. It is very similar to having the smear test. So you can see here the speculum, which is, you know, the quack instrument that we insert to expose the neck of the womb. And we did do that under ultrasound guidance. So we required having a full bladder, which sometimes can be a little bit uncomfortable. But it's the best way to transfer the embryo in a safe way. So what are the risks associated with IVF or with ICSI? This is the most dangerous risk that can happen in around 3 to 5% of the cases. Is a severe ovarian hyperstimulation syndrome. Is one when the ovaries over-respond to the drugs. So you can see the difference here from this, between this ovary and the one that I showed you before. This ovaries got lots of follicles, lots, around 30-40. You have to imagine this structure is like a ball, so it's not just what we see here, it's what is also in the depth, you know, in the third dimension that we don't see. So the same amount of follicles that you see here, they are actually present also on the back of the ovary. So the ovarian hyperstimulation syndrome actually can be life-threatening, so it's very important that we put in place a series of measures to prevent the occurrence of the hyperstimulation. But when the woman is at risk and we know that she's been identified to be at risk, then there are things that we can, strategies that we can apply to try and reduce the hyperstimulation risk. One of them could be to collect all the eggs and freeze all the embryos so that the pregnancy is delayed, and to give time to the patient, you know, to detox in a way from the drugs and go back to normal before actually she experienced the pregnancy. During the hyperstimulation phase, the woman can be really uncomfortable, experiencing symptoms which include nausea, vomiting, up until being unable to eat and drink. And if that is the case, then hospitalization will be required. Abdominal pain and distensions are very common as well. And on the other end, we might have the poor response when actually the patient doesn't respond to the stimulation drugs that we have allocated, we have given. And sometimes it's very disappointing, because if there are no eggs or very little amount of eggs, then the cycle needs to be cancelled. Sometimes we can offer another cycle with the different drugs. Sometimes this is not possible. So poor response is another potential risk. Allergy, obviously, to sedation and to the drugs that we use. Potential, very rarely, a risk of injuries to the internal organs and blood vessels, bleeding after the egg retrieval or infection. Failed fertilization. This is really frustrating. It does occur in about 5 to 7% of the cases when we put the eggs and the sperm together in the dish for IVF, and they don't seem to be interested in one and another, and they just don't fertilize. And that sometimes occurs in cases of unexplained subfertility, when we don't know why it doesn't happen naturally, but actually when we put them together in the dish, we understand that there is some sort of incompatibility between eggs and sperm, and that is what gives no embryos at the end. The treatment in this case would be the Icc treatment, which is when we inject the sperm inside the egg. So if the sperm is not interested in getting inside the egg, we actually force the sperm to go inside the egg by injecting it. Sometimes the embryos stop developing in the lab, and that again can be devastating, but these things can happen very rarely. Other potential complications are obviously multiple pregnancy, twins, triplets, they're very high risk pregnancy, and we consider them as potential complication, even if many patients would be happy to have twins. But you have always to remember that there are many risks associated with a twins pregnancy, or generally a multiple pregnancy. Miscarriages, this occurs usually in 1 in 4 couples, unfortunately, miscarry on the first pregnancy, and this is what happens also after natural conception, so it's not increased by the IVF. Ectopic is around 3 to 5% of the patients will experience a pregnancy which is not in the right place, but it could be outside the tube, outside the womb, in the tube, on the ovary, or sometimes in the actual abdomen, in the belly. I did put also ads on COVID-19, because with this many visits at the hospital, depending on the infection rate, then there could be the risk of catching the virus as well. And then the treatment failure, when obviously you have a negative pregnancy test, and that is happens unfortunately in majority of the cases. So finally, I just wanted to remind you that these treatments are extremely stressful and extremely time consuming. It's not just one visit, it's not just one tablet, it's a lot to go through. So please just, if you are about to embark a treatment, then just give yourself some space, and perhaps just push away things that can, make your life more complicated. Try not to combine, the treatment week with a busy working week. Think about that. It's not just a walk in the park, really, but can be quite demanding physically, emotionally, for both, for the couple. And obviously counseling and support through, societies like fertility networks are always available there. So tips that could help in work would be, for example, to have a fridge, because all our drugs needs to be refrigerated. So it might be useful for have just a designated fridge for the drugs to be stored, and to have a dedicated room at work for a private video consultation. Nowadays with the COVID, we've been doing attend anywhere consultations in the hospital, and or Zoom meetings privately as well. So it's very important to have a quiet room to take these phone calls or these video calls, a private room to inject, because as I say, those injections have to be taken at a certain time, and obviously if the patient is at work or they have, and there is no possibility to delay the injection, because that will affect the treatment. and fertility champions of work. I will leave that to my colleagues, Ellen, to discuss. So with this, I think, yeah, I just wanted to conclude with this article that I read, that I found it very interesting, to say that maybe reproductive leave should be considered and introduced for couples or patients who have miscarriages and IVF. But this is a proposal. It's a recent article. So things are moving, I think, in the right direction in our field. And I feel this is very encouraging. And please keep following me, make friends, and, you know, and contact me on social media. Okay, thank you very much.
Well, thank you very much, Ariana. A wealth of information there about the actual process and the risks and the successes, obviously, of the system. So thank you ever so much for that, and some great tips at the end there about some of the practical things that people need to ensure they have in place when they're going through it, when they're working. Also, yes, good to see that article at the end. I hope that our own UK government will be as enlightened as that Irish Times article seems to suggest the Irish government are being. So without further ado, Helen, can I introduce you again and let you crack on with your own fertility journey, which you're going to talk us through. Thank you.
Thank you so much. Morning, everyone. It's still morning, isn't it? Yes. Just checking you can hear me and see my screen. All okay? Perfect. Great. So just to recap who I am, I guess. So I'm Helen. I've recently just turned 40 and I hail from Cardiff. So I'm going to share my journey with you in brief. But for some reason, I can't go to my next slide. There we go. Let me just do that. Okay. So this is me. So this is me about 6 years ago, and this is me today. I look very different, actually, I think. Yeah, so the first thing I actually want to say to everyone that's listening today is, and as Alice and Ariana and Fleur will talk about as well, is you're absolutely not alone on your journey. You may feel like you are, but you're absolutely not. So please do reach out to the amazing support networks that are there. Fertility Network, Wales UK, and the online community is huge. So please do lean into those resources if you feel you're able to. They are a brilliant bank of knowledge, so do lean into those. So 2015 is where it all started for me. Me and my husband got married that year, and as most people do after they get married, is they try for a family. And we didn't think for any reason that we would have any problems to conceive. I'd come off the pill and, you know, really enjoyed trying for a family, and unfortunately things just weren't working for us. We'd gone through sort of every method to try and get pregnant, you know, the whole thing of put your legs in the air after you have sex, you know, that'll help. It didn't for us, unfortunately. But after about 9 months of trying, we did actually fall pregnant. We fell pregnant naturally. And that was great. You know, we were obviously very pleased and happy. And unfortunately, about 2 to 3 days later, after we found out we were pregnant, I started to bleed, and that's when I had my first ectopic pregnancy. I won't go into detail on that because it's very sensitive, and I appreciate some people on this call might be on their own journey. But in brief, I basically had a C-section and without the baby, and it was a life-threatening operation, and I nearly died. And you can imagine the emotions that were involved in that. You know, I had to learn to walk again. And at that time, I was running the large multi-million retail business. I had a business partner who was very supportive, but we just didn't really talk about it. it was just one of those things that I was more interested about getting back to work and making sure my team were okay, and I didn't really consider my emotions at that time. So I'm just going to go to the next slide a sec, because my journey lasted about 5 years. I went to roughly over 50 appointments that I can actually remember. As Ariana was talking then, I remembered that, God, I had the H-Cozy procedure as well, which I'd forgotten about. Unfortunately, I did suffer another miscarriage, and after my first ectopic, I found out that I actually had a vitamin D deficiency, which you talked about, Ariana, and it's really interesting. I wonder if that actually had any impact on me trying to conceive. I don't know. I was diagnosed with unexplained fertility. Fast forward a number of years, a number of emotions that made me feel comfortable in trying for a baby again. Sorry, I forgot to mention, I lost my left fallopian tube on my first ectopic pregnancy. And I also discovered I had a mutated gene, which, if you can see on the screen, it's shortened to MTHFR. It's a really long word, and I can't actually say it, and it looks quite rude with the abbreviation. But it means that my body doesn't absorb folate, and it's subject to blood clotting, which is a really, really big diagnosis for me, because it was kind of a flip in my brain that thought, okay, is that why I'm having problems conceiving? I don't know, but it could be a reason. So fast forward a number of years and more investigations, and we had our first round of IVF, which was undertaken at the Wales Fertility Institute in the UHW here in Cardiff, and that was a positive round of IVF. And unfortunately, after the treatment, I was diagnosed with another ectopic pregnancy. What are the chances? I had 2 ectopic pregnancies already. So again, my emotions were very heightened. It was a very stressful time for me. And at that time, I was just about to exit, sell my shares in the business. So trying to deal with my fertility and trying to sell a business at the time was the most stressed I think I've ever been in my life. And I didn't feel that I had much support around me at that time. It was a strange time for me, but I got through it. I absolutely got through it. But I did lose my final fallopian tube on that second ectopic pregnancy. So obviously then the only obviously opportunity to get pregnant was to go for another round of IVF. And that took me a while to come around to the realization that my only opportunity now for to have a family was via IVF. So we took some time, me and my husband took some time, and we did decide to go for another round of IVF. All that journey, it was over 5 years, and there was a lot of treatment, a lot of appointments, a lot of time, and a lot of mental exhaustion from all the things that we had to go through to try and get a family. And it's as Ariana said, it's challenging, it's exhausting, and it's very complex as well. And I guess one of the things really, obviously now in fertility in the workplace, is can work also affect your fertility journey? And also vice versa, can the fertility journey affect your work? In all honesty, I would say yes. It impacted everything I did. I was physically present in work, doing the best I can, but sometimes mentally I just wasn't there. And if, for example, I knew I had to go for an appointment, my mind would be focused on that rather than actually focusing on my work. And that wasn't actually fair on either myself or my business, my team, or any employers. So you've got to think of that. So if you do know that you're going to go to an appointment or you've got something coming up that day, is it fair on you or the business to be present but not actually showing up in work? So I would say that it's really important to give yourself time before and after an appointment to really take everything in. So, you know, you are the most important thing on your fertility journey. An email can wait, you know, an email can be there tomorrow. So I would absolutely say that make sure that you give yourself the time that you need before and after appointments. It's really, really important. Okay, so self-employed versus employed, does it actually matter? So when I was self-employed, my focus was my business. I was really passionate about my team. I wanted to make sure make sure they were okay, make sure that they were paid on time, you know, make sure that the stock was getting into the stores. That was the absolute priority for me. And the very beginning of my journey, I was self-employed, and after every appointment, I went back to work. Even after the tears that I'd had with a consultation, you know, found out I had the mutated gene, I always went back to work, and I didn't give myself time to really take in the information that I'd just been given. And at the time, like I said, I had a business partner and she was very supportive, and we didn't really talk about me going back to work. It was just something I just did. And I guess just what I would say is, again, just make sure you think about yourself. Unless you work in an industry that's, you know, you have to go and do a life-saving operation and you're the only person in the world that can do it, there is always somebody else that can do something for you in work. So when I sold my business, I took some time out, and then I decided that I wanted to go and work for someone else for a bit. I didn't want the stress of having my own business. And that coincided with me going to have my final round of IVF. And the discussions I had with my director at the time were so supportive. I cannot tell you how supportive that person is. She's become a really lifelong friend because she got me through some dark days in work. She didn't actually understand what I was going through, but she gave me the support and the flexibility that I needed to be able to take time to go to my appointments. There was never any pressure to come back to work. I had to dash out to have some IVF treatment at a big conference once. I was running this conference for her, and I had to go and actually, you know, get to the hospital and have some treatment. But there was no pressure and there was no questions asked. It was just do what you have to do to make your journey easier. And having that flexibility from that employer was a game changer for me. Fertility is tough, it's long, it's complex, and you just don't need your work making it seem like there's more barriers to get through. So that for me was real game changer. We also implemented a fertility policy in that business, because not only for myself, I was going through treatment at the time, but also for the team that we had. There was only 8 of us, but the statistics show, as we've talked about, 1 in 6 people are likely to be diagnosed with some kind of infertility or challenges. So I wanted to make sure that the rest of my team were supportive in that way. So the way I think of fertility, if you're on a journey, is I relate it to a bike analogy. So think of it as if you're going on a really long bike ride up a never-ending steep hill, that have got some spikes in the road, you could be falling off a cliff, that could give you a puncture on your bike. How would it be if somebody came on that journey with you and offered you some water when you're trying to get up that steep hill? Would that help you on your journey on your bike? Probably yes. What also if somebody came to chat to you on your bike ride and just made that journey a little bit easier and tried to encourage you and support you to get to the end of the steep hill? Would that help and support you? I'd probably say yes. So think of it from a workplace point of view. You may not understand what people are going through, but if you can offer them some water on their journey, offer them some support in a chat, it will absolutely help them. So what can employers do? There's so much employers can do, and I know Alice and Ariana have touched on it a little bit already, but the most important thing for me is for employers to be flexible. As Ariana just explained, you know, the procedures can be quite lengthy, they can be fairly short, and they're so individual to people that you know, not a one solution fits all. So just be as flexible as you can. Be supportive as well. Like I said, you may not understand what they're going through, but just have that supportive network is really important. If you haven't got a fertility policy in place, then I would say to get one instilled as soon as possible, and make it fair and again fairly flexible. So it's fair for both the business, the employer, and the employee as well, and have that safe space that somebody can go and talk to if they need that wellbeing champion. Think about what you say. Oh my goodness, Alice mentioned it, but if one more person would have said to me, oh, just relax, it'll happen, I think I really would have punched one more person in the face, because it doesn't happen for people. So one thing I would say is, if you don't understand what somebody's going through, say that to them and say, I don't understand the procedures or the process, but I'm absolutely here to listen and support you if you need that support. Normalize the conversation. It is very common and it's not a taboo subject. Have potential lunch and learn sessions. You know, you can have pre-recorded webinars these days if people don't want to show up to sessions. It's all about educating people, and you know, Fertility Network are doing some fantastic things about educating from a young age as well now. So it's just educating the people around you, your colleagues, your peers, senior leaders as well, and business owners that just don't understand. And also think about the industry you're in. So I talk to a lot of people, and for example, teachers, they cannot always have their consultations or their treatment in the summer holidays. You know, so think of the industries you're in and be that flexible and supportive person. My husband actually works for the public sector, and they were a fantastic support for him as well. So, you know, there are industries out there that are being supportive to their employees. Okay, positive versus negative emotions, what are more powerful? I cannot tell you how many negative emotions I felt throughout my journey. I felt shame, I felt failure, loss of control, overall sadness, but actually those negative emotions will not help you. You know, that we all know positivity and creates you know, positive hormones inside you, feeling good, and you can't always feel positive all the time, I get that. But those people in your support network, if they can be that positive person for you when you're just not feeling very positive, lean on them. Negative emotions just suck the energy out of you, and you know, going through fertility is challenging. So if you can focus on three things. And also from an employer's point of view, I would say to try and visualize the positivity. How do you want to feel? Focus on the optimism, because there is, you can be optimistic. Think about all the journey I've been on. You know, I had to try and be optimistic. I wanted to get a positive outcome, and I appreciate that doesn't happen for everyone. But if you do foster the hope, you know, it will help you on your journey. And from an employer's point of view, if you can be all of these for your amazing employees, it will make such a difference. It will feel like the weight is being lifted off your shoulders, and you can go to your consultations, you can go to your appointments with ease and support. It will be a real game changer for them. And lastly, dreams can come true. What I didn't say was, on our final rounds of IVF, we had one egg transferred, and that egg split and created our twin girls, identical twin girls, Bella and Sophia, who are now 13 months old. So thank you all very much for listening. That was a really short and very quick introduction into me. So I hope that's helped a little bit, and I'd be more than happy to you know, keep in contact with you and explain things a little bit in, you know, more detail if you need to. So thank you. There we go.
Thank you ever so much, Helen, for that very personal journey through fertility treatment, and what great news at the end.
Yeah.
Happy photos with all of you there. So very good news indeed. So I'm going to talk now briefly about some of the rights both rights employees have in the workplace when they're going through these processes. And also giving some tips to those of you who may be here because you are an employer or working for an employer and responsible for trying to make things right for these people who are going through these processes. We've already heard about a lot of the sort of soft things that employers can do, and you know, very constructive things that employers can do to put things in place to support employees. What I'm going to focus on briefly is what protections in law people have, women in particular, if their employers aren't doing the right thing by them. I don't have slides, but what I do have is an advice note or some bullet points that I will share with you all, along with this recording, which includes sort of an overview of the law and a few top tips from an employment law perspective that you as employers can adopt, and you as employees who are going through this can actually use to try and persuade your employer to do the right thing by them. So first off, protection based on pregnancy and maternity. Pregnant women are protected from dismissal, detriment and discrimination because of their pregnancy or maternity. So don't forget that. And the protected period begins when a woman becomes pregnant and ends either at the end of her maternity leave or 2 weeks after the end of her pregnancy. And discrimination on the grounds of pregnancy is automatic discrimination, and there's no need to look for a male comparator, because obviously pregnancy is a condition which is only applicable to women. In the context of IVF treatment, the protection period starts when fertilized ova are implanted. So the woman is considered pregnant from that point onwards. If the implementation fails and the pregnancy ends, the protection ends after a further 2 weeks have elapsed. So effectively, if an employer treats you as an employee, a female employee who's going through that process, from the point when your fertilized ova has been implanted to the end of your pregnancy and 2 weeks thereafter, you could claim pregnancy and maternity discrimination. Now, obviously, we all hope that that's never going to be an issue, but you would be surprised how many women unfortunately experience such problems. with thoughtful and uncaring employers not really understanding the huge stress they're under and not treating the fertility treatment with the respect and the sort of care that it should as an employer. There's also, in addition to protection based on pregnancy and maternity, there's also protection based on sex available to people undergoing IVF treatment. There's an additional limited period of time before the implementation, which is the time taken for the ova to be collected, fertilized, and for the immediate implementation of the fertilized ova afterwards. If an employer treats an employee less favourably because she's undergoing IVF treatment, that's likely to be that there's discrimination on the grounds of her sex. It's not because she's considered pregnant, but because she's undergoing this process, but she will need a male comparator to prove that sex discrimination happened. And I'll come on to give examples of what that looks like later for you. So this is limited in scope, this protection of sex discrimination, because the current position, and which is endorsed by the EHRC, is that the period of protection doesn't apply to a long period between the freezing of fertilized ova with a view to implanting it at a later date, because obviously fertilized ova can be kept for many years. The possibility of there being a long period in which implementation could be contemplated, would mean there would be no definitive point at which it could be said the pregnancy had come to an end. There is a limited, therefore, and closely defined period of protection for sex discrimination in this context, the stage between the follicular puncture and the immediate transfer of the vitro-fertilized ova. There's currently no automatic right to time off work for IVF treatment, but employers should treat these time off requests sympathetically and must not treat the female employee less favourably than they would treat a man requesting time off for medical treatment, because obviously this could amount to sex discrimination. So a couple of examples of potential sex discrimination for you in the first instance. So a female employee is undergoing IVF treatment and she has to take time off sick because of the side effects. Her employer treats this as ordinary sickness absence and pays her contractual sick pay that is due to her. If the employer decided not to do that and not to treat the time off sick because of the side effects of IVF in an ordinary sickness absence way, that could indeed amount to sex discrimination. So the fact that you are going through a treatment which is causing you to be ill shouldn't mean that you are treated any differently to any other type of absence due to sickness. So bear that in mind when you're in discussions with your employer. Another example is an employer grants a week's annual leave for a male employee so he can undergo cosmetic surgery. A few months later, a female colleague makes a request for a week of annual leave to undergo IVF treatment. The employer refuses the female's request, even though she still has 2 weeks of accrued leave to take. Now that person, that female, could potentially argue that her employer's refusal to grant her request for annual leave for IVF treatment amounts to sex discrimination by comparing her treatment to the male colleague who's been allowed time off to go and have cosmetic surgery. So there are lots of pitfalls for employers here, and as I say, lots of employers are very good and considerate, and what I'm giving you is the letter of the law, other than how nuanced this subject can be, as we've heard from Ariana, Helen and Alice. But it is good to know that as limited as it is, there is protection out there, and employers need to be mindful of that protection and to try and act not only within the letter of the law, but to consider putting in place, the top tips that Ariana, Alice and Helen have referred to. So there are some barriers obviously to discussing fertility in work, as Helen in particular particular mentioned, you know, it's seen as a very sort of private matter for whatever reason, and it's not therefore the subject of robust policy discussions amongst employers. This can obviously mean, and we've touched on this already, that employees can feel very isolated and basically feel unable to share their fertility issues. Hence why Ariana was mentioning, you know, having a fertility champion in a workplace is a fantastic idea. Some women don't want to tell their employer that they're actively trying to get pregnant because they fear detrimental treatment, either due to the stigma or the sort of biggest picture of being pregnant or going on maternity leave. I can't tell you the number of times I've advised employees who, when they've gone for interview for jobs, and they're of a certain age, between sort of, I say 25 to 40, and the employer takes a good look at them and asks them what plans they've got for starting a family. It still does happen. No, you know, no word of a lie. My best story is, in fact, for an employer client of mine I was acting for, who confessed to me very happily that he had interviewed someone in their early 30s and had said as follows to her, well, you seem to have very good teeth. What's your plans for, I don't know what the connection between teeth and the reproduction is, but what's your plans for starting a family? So as you can imagine, that didn't go down well. And this is why women in particular are very reticent about sharing their family planning plans, because they fear some kind of detrimental treatment, and obviously the fact that, you know, their careers might be hampered not only by going through IVF treatments, but also then by hopefully the ensuing pregnancy. If IVF is unsuccessful, there's a miscarriage, employees may often not know who to talk to at work. I think whilst our HR functions can you know, do a very good job in the workplace, sometimes they can be seen to be a little bit distant, and possibly there's a room here to have mentors introduced into the workplace, where people feel that it's not their direct line manager, it's not their HR manager, but they've got someone they can turn to explain and to confide in about the issues that are caused to them, particularly obviously if the IVF is stressful, unsuccessful, or there's a miscarriage effectively. Compassion and sympathy are the key words here, and employers need to remember that and to act accordingly, and not, as I say, by the letter of the law. Lots of women and men are very also unsure what their rights are in terms of fertility issues. You know, it's not very clear, it's not as well defined as we'd like it to be. Obviously, there is much more work to be done to protect employees in this field. And I think probably if there wasn't so much stress associated for employees in the workplace, maybe the problem would be not as great as it is in terms of people's general stresses that sometimes can contribute to the issue, which means they have to face fertility treatments. So there's a lot of work still to be done on this, but having an open door and an open policy where employees can feel reassured that you as an employer understand what your duties are, and also to encourage people to talk freely about them and to explain to people what their rights are, surely is something very good that an employer can do, and something as well employees should ask for, and, you know, take the initiative to try and lead the bandwagon on this if necessary. Let's not forget as well that fertility issues can also have a very detrimental impact on men. They may be suffering from infertility themselves, or obviously they are being supportive and part of the IVF treatment for their partner. Because the fertility on the whole is seen as a sort of female issue, it's always our fault, isn't it, for everything? It's easy for men to feel that they can't speak out at work. They might not want to divulge what their female partners are going through, how it's impacting on them. You know, lots of men report feeling low and anxious, as much as women do, because obviously it's a big thing, it's a joint thing, and as Helen was mentioning, we got pregnant, she said, you know, it's about two people, not one person. It's not about the female only, otherwise no babies would be made. And it's very important to remember this, because I think men can often suffer in silence, and if employers are aware of that and make sure that they appear supportive of men as well, then surely we can start to lift some of this stigma and certainly make sure we avoid any discrimination issues arising. Because the adverse impacts, if employees can't openly discuss this, can be very significant. They basically, obviously looking down the barrel of poor mental health. We all have talked a lot about mental health in the last year, particularly because, you know, the effects of the pandemic has been great on people. But let's not forget, it's been very great on those who were going through IVF treatments, but all of that was paused due to lockdowns and so forth as well. And, you know, as Ariana, I think, was mentioning, for the female, obviously age is a massive factor. And if you are creeping towards 40 or 43, and that clock was ticking whilst the pandemic was on, I'm sure it would have led to a very, very stressful time. But even if you're just going through it in a non-pandemic way, and without the constraints we've been facing at present, poor mental health can be associated with it. Helen explained directly how stressful the situation was on her, particularly as she was juggling quite a large transaction in her business life at the same time. Because what poor mental health does is result in poor work performance, lack of motivation and productivity, because people are tired, distracted, anxious, and so forth. And of course, it actually leads to an increase in sickness absence, not for reasons directly linked to the IVF treatment, but just because the situation is too bad and people don't know where to turn. Therefore, they just use your sickness absence policy to take time off whilst they're going through this. In a long-term capacity, and obviously these fertility treatments can last a long time, as Ariana was explaining, and they're very difficult things to go through. That can be linked with poor mental health that in turn can turn into a disability under the Equality Act of, you know, because obviously depression and anxiety can be recognised disabilities within the sort of workplace context. So again, whatever an employer can do to support people through this process is incredibly important. And of course, whatever employees can do to help themselves and to be bold about this and to speak openly about it and so forth, and to make sure they break down boundaries whilst they're going through it, then all the better, because otherwise it's just a lose-lose situation. The employee ends up feeling isolated and anxious, and the employer gets frustrated because they feel they're not getting what they should be out of their employee, but they can't join the dots and see that probably it's their attitude that is perpetuating the problem. So the worst case scenario is you end up with people raising grievances because they don't feel supported properly, and ultimately it can involve dismissals and claims for discrimination and so forth, which is clearly something that no employee wants to have to go through whilst they're also facing IVF treatment. And also it's not anything an employer in its right mind would want, because it's massively costly in terms of management time and obviously legal fees as well. So if an employer can take some time to try and understand the issue at hand, they can, as I say, make sure an employee is treated with compassion and sympathy. I've already mentioned the fact that mentoring is a very, very sensible idea in such contexts, because sometimes people don't feel comfortable speaking to their line manager or to the HR manager about it. And obviously reaching, front foot the issue, reach an appropriate arrangement for all parties concerned about how absences are going to be dealt with. What policies can your company stretch to that will enable people to feel comfortable around this issue and not to feel stressed that they're having to take time off or whatever else is necessary to allow the treatment to go ahead. Working flexibly, if this pandemic's taught us nothing else, we know how to work flexibly now, don't we? Particularly those with children who've been working all hours of the day other than when they're looking after children. So working flexibly is something that definitely in most jobs can be accommodated. Employees should feel emboldened to ask for it, and employers should feel that they really need to do some soul searching if they're going to turn down a request for flexible working in this context. Obviously, if there are issues that could involve disability, then obviously you also as an employer need to think about what reasonable adjustments to put in place to support the employee through the process. Hopefully, if you've been good with flexible working and setting out the parameters in which a person can feel supported through fertility treatment, then obviously you will not need to discuss reasonable adjustments. But you know, there's a lot of work that can be done, a lot of soft things that could be done, like advertising and signposting staff to relevant organisations such as the Fertility Network to assist people through this. Those of you who will have been here today will have also heard from Helen and Ariana, and as Ariana said, follow her on social media and so forth, and get in touch with Helen as well. But obviously the Fertility Network Wales is there absolutely to support people through these processes. Having that person within the organisation who's in a mentoring capacity that's able to speak on a confidential basis about fertility issues is very important. And also, you know, get in touch with people who are specialist speakers in this subject, so that your employees can see that you are completely and utterly supportive of this, and that you understand how important it is to a person. Because let's face it, a person who is happy in their home life normally is a happy employee, because the two things go together. If we're facing challenges of whatever nature in our home or personal life, they more than often than not translate to the work environment. And that's why employers should do what they can to try and support people through this process. And my last word on the matter is policy. That old chestnut, all of the things I've just talked about needs to be supported by a comprehensive policy that sets out in one place what your employees can expect of you. Now, a policy is only as good as its implementation and development and deliverance. So start with a policy and then make sure that you put the building blocks in place. And if you are the employee going through this, be emboldened to raise this issue with your employer and make sure that you try and lead the conversation, because even if it doesn't help you directly, you can be absolutely assured that it will help others. So that's all I was going to say from the sort of employment law perspective. I appreciate that we were meant to finish about 20 minutes ago, so I've done a gallop through my session. If anyone's got any questions, we're very happy to take those briefly. There's just one comment in the group chat at the moment, but if anyone else has got any questions, we'll take those. Doesn't seem that like there are. What we will do, as I said, is send out the recording of this session to you all, along with my bullet point notes. I'm sure we could make the slides from the other speakers available too. I'm looking to everyone to see if everyone's happy with that. Yes, so we'll do that. And obviously then if you do have any questions or queries, you will have our contact details, and you are very welcome to get in touch with us as you see fit. You know where we all are. We're not hiding any contact details, I don't think. So thank you very much, and thank you ever so much to my fellow speakers. I think it's been a very informative session covering all manner of aspects of this very thorny and difficult issue for many, and I hope you found it useful. And on that note, unless anyone's got anything more to add? No, everyone's shaking their head. Thank you ever so much, and yes, look forward to seeing you all soon. Thank you.
Thank you. Goodbye.
Bye.
Bye.